Thanks, Chris, for that wonderful talk. Next will be kind of a dual presentation from Brad Henricksen from here at the University of Utah. And the first talk will be examining the effects of maternal nutrition on macular development, and then his second talk will actually be a case presentation on visual distortions.
All right, first of all, I'd just like to say thank you for the opportunity to present at Ground Rounds, both the research presentation and case presentation as part of my 2 clinical rotations here at the Moran. And if any clarification was needed, I do not have ocular albinism, although I thank Chris for the great overview. So the title of my research presentation today is Examining the Effects of Maternal Nutrition on Macular Development. For background information, of the about 600 carotenoids that exist in nature, 50 are found in the human diet, mostly in fruits and vegetables. About 10 to 15 types of carotenoids are found in the human serum. However, only 2 types of carotenoids, lutein and zeaxanthine, are found within the macula. This image here shows tissue fixation of the macula luteae. The central yellow pigmentation is a result of carotenoids in this region. The carotenoids lutein and zeaxanthine of our particular interest with macular protection. The structure, molecular structure of lutein and zeaxanthine with a large amount of conjugated double bonds allows for the stabilization of free radicals created with oxidative stress. The role of carotenoids in slowing the progression of age-related macular degeneration has been well outlined and studied in the AREDS and AREDS 2 trials. And the potential for lutein and zeaxanthine for decreasing oxidative stress and retinopathy of prematurity is also an area of great interest, although randomized controlled trials have yet to confirm this relationship. So the role of carotenoids in macular development is not well understood at this time. Carotenoids have been detected by HPLC in cadaver eyes at 20 weeks gestation, although no pigment was visibly detectable at that time. Progressive shifts in the distribution of lutein, zeaxanthine, and mesozeaxanthine, a zeaxanthine metabolite, within the macula occur at different developmental stages. In 2013, Dr. Bernstein and associates reported quantification of macular pigment optical density by RETCam imaging and blue light reflectance in infants and children. The main findings from their study were that macular pigment was not detected by non-invasive invasive imaging in premature infants, and macular pigment increased with age. 2 main follow-up questions arose from this study. One was, what were the macular pigment levels in term infants at birth, and what was the role of maternal nutrition in macular pigment deposition? This brings me to the report of our study titled Interrelationships Between Maternal Carotenoid Status and Newborn Infant Macular Pigment Optical Density and Carotenoid Status. The purpose of our study was to examine the relationship between infant and mother carotenoid status in newborn term infants, and our study population included 30 healthy term infants and their mothers, as well as 10 intrauterine growth-restricted infants and their mothers. All infants were between 24 and 72 hours of delivery at the University of Utah Hospital. With regards to our methods, the measurements for infants included skin and serum carotenoids, as well as MPOD in a subgroup of 14 infants. Mother measurements included skin, serum, and breast milk carotenoids. Quantification of the serum carotenoids was completed by HPLC. Quantification of the skin carotenoids was completed using Raman spectroscopy. An example of the probe used in Raman spectroscopy is shown in this photo here. And finally, quantification of MPOD was completed using RETCam imaging and blue light reflectance. An example of the RETCam device completing macular imaging is shown here. The resultant blue light image is then passed through an FFT bandpass filter to create this image. And from that image, we're able to create both a 3D map as well as linear macular density plot. On to our results. In this figure, we can see that mother total serum carotenoids correlate with infant total serum carotenoids. This relationship was also present when we looked at mother serum zeaxanthine levels compared to infant serum zeaxanthine, as well as mother serum lutein levels and infant serum lutein levels. This figure shows that mother skin carotenoids correlate with infant skin carotenoids. And then the bottom two figures show our controls, that infant skin carotenoids were also correlated and representative overall of infant total serum carotenoids, as well as this relationship between the mother serum carotenoids and mother skin carotenoids. In this figure, we see that infant serum zeaxanthine levels correlated with infant macular pigment optical density. However, this relationship was not present when we looked at infant serum lutein levels and compared those to infant MPOD. The results on this ladder, perhaps the most interesting of the study. Here we see that mother serum zeaxanthine levels correlated with infant MPOD. Again, this relationship was not present when we looked at mother serum lutein levels compared to infant MPOD. And a brief summary of the findings of our IUGR groups. So infants affected by intrauterine growth restriction did not show significant differences for total serum carotenoids or skin carotenoids when compared to healthy controls. However, mothers of IUGR infants did show decreased total serum carotenoids as well as decreased breast milk carotenoids when compared to healthy controls. So the conclusions from this preliminary study are that macular pigment is present and detectable via RETCAM imaging in term infants. This suggests some role of pigment deposition in utero. And infant as well as mother zeaxanthine levels correlate with MPOD. This suggests a role of maternal nutrition in macular development. And mothers of IUGR infants had lower carotenoid status, but their infants did not when compared to controls. This suggests a possible nutrient-sparing mechanism with regards to carotenoid deposition. And finally, an interventional trial really is needed to address the causality as well as clinical significance of our findings. We are planning a follow-up study, the maternal carotenoid supplementation study. The hypothesis of this study is that prenatal supplementation with lutein and zeaxanthine will increase infant macular pigment levels as detected within the first 2 weeks after delivery. The design of our study will be a randomized controlled trial, with the intervention being prenatal supplementation with or without lutein and zeaxanthine. And we will begin supplementation at 28 weeks gestation for the duration of the third trimester. We plan to enroll 30 mothers per group. And our main outcome measures for mothers will be skin and serum carotenoids, both at baseline and within 2 weeks of delivery, as well as breast milk carotenoids within 2 weeks of delivery. Our main measurements for infants include skin and serum carotenoids, as well as MPOD and OCT of the macula within the first 2 weeks after delivery. We plan on a 1-year follow-up, at which time we will measure mother and infant skin carotenoids, as well as infant visual acuity. We are in the process of preparing and submitting an NIH supplemental grant to help fund this follow-up study with our target enrollment date of January 2015. I'd like to thank the many mentors and supporting staff who made not only our first study possible, but the upcoming study, especially Dr. Hoffman, Dr. Hartnett, and Dr. Bernstein here at the Moran Eye Center. These are our main funding sources, and these are my references, and I can take any questions at this time. I think that's an excellent question. Prior to our first study, that we really didn't have documentation of macular pigment at birth. So when we found that, we weren't sure necessarily the clinical impact of having lower levels or higher levels of macular pigment at birth, as well as the supplementation. As I mentioned kind of in the introduction section, there is a potential role for carotenoid supplementation and the prevention of retinopathy of prematurity. However, our main focus for our follow-up study is in term infants as, and the potential for increasing protection going forward after a term delivery, as well as possibly visual function. That's why we're extending our follow-up period to 1 year. I guess another thing that would be relevant to your question is that now in the prenatal vitamin supplementation world, Abbott Nutrition has introduced a supplement with lutein and zeaxanthin added to it. And so another question is, does that significantly impact visual function as it is now part of the American market? Yeah.
Three component to this at all? You're looking at the mothers that have a lower carotenoids, they're stronger, AMD in those families, or did you look at that at all?
We haven't looked at that yet. With our follow-up study, we plan to do kind of more extensive diet logs as well as history, but that's not something that we included in our initial study. Okay. All right. So I'll now change directions and start the presentation on the case of visual distortions. This is a 41-year-old man with no significant medical history who presented with complaints of visual distortions. Pertinent positives from his history of present illness include flashing lights and bubbles in his left inferior visual field that had began 4 weeks prior to his presentation and were aggravated by changes in the position of his eye as well as changes in position. He also complained of distortion of lines on a page in his left lower visual field that began 1 week prior to presentation. And he was evaluated by an outside retina specialist who did not identify any posterior vitreous or retinal detachments. However, mild elevation of his left optic nerve was noted on exam. At his initial evaluation in the Neuro-Ophthalmology clinic, his visual acuity, pupils, pressure, and visual fields to confrontation were all within normal limits. His extraocular movements were intact. Color and stereo vision were also intact, and there was no red desaturation. Slit lamp exam of the anterior structures as well as the lens and vitreous were within normal limits. And his fundus exam showed a cup-to-disc ratio of 0.3 on the right with no optic nerve swelling, and a cup-to-disc ratio of 0.3 on the left with some mild superior swelling and attenuation of an arterial nasally. This was given the stage of stage 1 optic nerve edema. On fundus photography, we can see this mild elevation of the optic nerve superiorly, as well as an attenuation of a vessel here nasally. On fluorescein angiography, there was adequate filling of the vessels, as well as some late leakage at the disc. His visual field shows some very mild inferior deficits on the left eye and normal visual field on the right eye. OCT showed papilla on both optic nerves, suggestive of Burgmeister papillae, and some mild vitreous syneresis, well, that's difficult to appreciate on the projection here. And then the RNFL shows that superior thickening of the optic disc, as well as over here. So the differential diagnosis for a patient presenting with these symptoms is very broad. However, our main 2 diagnoses that we were considering at the time of presentation were a mild case of anterior ischemic optic neuropathy, or AION, versus vitreopapillary traction. This patient really didn't have many risk factors for AION. His cup-to-disc ratio was 0.3, so a possible disc at risk, and he didn't really have any other cardiovascular risk factors. He did have some vitreous syneresis present with papillary tufts on OCT, which was suggestive of VP traction. Other causes of optic nerve swelling include infectious, inflammatory, or autoimmune, hypercoagulable, and malignant conditions. And our initial workup included several labs listed here, as well as an MRI of the orbits and face with and without contrast. So a little bit more about vitreopapillary traction. It's defined as vitreous traction at the optic nerve head, often due to partial posterior vitreous detachment. Exam findings usually include optic disc elevation and blurring of the margins. It may also include retinal or disc hemorrhage or an epiretinal membrane. Special testing may reveal visual field defects on Humper visual fields. OCT findings include the vitreous traction near the optic nerve head, as well as, in some cases, inclusion of the macula, and then peripapillary thickening. FA findings are usually associated with focal leakage and at the optic discs. So documentation of VP traction and OCT. This is a case report showing OCT findings in the case of VP traction. You can see the obvious traction here at the optic disc as well as at the macula that resolved after vitrectomy. Here on fundus photography, you see the blurring of the margins of the optic disc, which also resolved after vitrectomy. On this case report, we can see the papillary tufts, which were similar to the tufts seen with our patient, as well as some late leakage on FA, which was also similar to the patient that we saw in clinic. This is a brief overview of the main characteristics of VP traction versus AION. The clinical characteristics of AION that distinguish it from VP traction include color desaturation and sudden non-painful visual loss. OCT findings of vitreous traction are very suggestive of VP traction. However, there have been some case reports of AION with the presence of VP traction as well, so it's not necessarily specific. And then late nerve thinning on OCT RNFL is very suggestive of AION. On sign fluorescein angiography, you may be able to detect some delayed filling of the choroidal arteries in AION. And finally, late disc pallor and comorbid cardiovascular risk factors are suggestive of AION. So as far as treatments, the treatment for VP traction is not necessarily clear or agreed upon. There are some reports of close follow-up with visual field testing or others advocating for vitrectomy. For AION, the treatment usually includes ruling out giant cell arteritis, close follow-up, and there is also a potential benefit for brimonidine drops, although this hasn't been confirmed yet with randomized controlled trials, as well as decreasing cardiovascular risk factors and avoiding nocturnal hypotension. So follow-up, getting back to the patient that we saw in clinic, all of his labs came back within normal limits. His MRI of the brain showed no abnormality of the optic discs or otherwise. Sorry, of the optic nerves or otherwise. And our preliminary plan with him was to start brimonidine drops, have close follow-up, and recommended a visit to his primary care physician. At his first follow-up visit, the severity of his symptoms was unchanged, and he had developed in the interval, an APD on his left eye, And at his second follow-up visit, his symptoms had started to improve, and this APD was no longer present in the left eye. At his most recent follow-up visit, his photopsias had completely resolved. Taking a look at the imaging for him and special testing, so visual fields, at the initial visit, we have already seen this mild inferior deficit, which seemed to worsen at the first follow-up visit and then began to resolve by his second follow-up visit. OCT RNFL of the left eye here highlights the progression and changes in the left optic nerve. Initially, he had the marked elevation of the superior optic nerve on the left, which started to decrease and came back to nearly normal levels by his second follow-up visit. However, his optic nerve continued to thin at follow-up visit number 3 here, possibly below baseline levels. Although we don't have a true baseline for his left eye OCT RNFL, we can compare it to his right eye, which has been stable throughout his course. And the average thickness for his right eye was 102 compared to 95 in his left eye, which suggests that there may be an additional thinning instead of just returning to his baseline. So the major conclusions from this case is we have yet to come to a definitive diagnosis at this time, although AION does seem most likely due to the decreasing optic nerve thickness. VP traction is difficult to distinguish initially from AION based on OCT and FA findings alone. Both of these conditions may be present simultaneously or may be misdiagnosed. And finally, following the progression of the optic nerve thickness with OCT, RNFL may be the best method for definitive diagnosis at this time. I'd like to thank Dr. Warner as well as the entire Neuro-Ophthalmology team for allowing me to see this patient as well as helping me with this presentation. These are my references, and this 2-year-old keeps me busy. I'll take any questions at this time.
Could you document any separation of the vitreous that was at least thought to be causing traction initially on the serial examinations that would go along with maybe a decrease in the edema?
From the best of my understanding, we didn't document any posterior vitreal detachments at the time of presentation, and I'm not sure as far as the follow-up visits, but
Because that first OCT did seem to show maybe a traction on that.
yeah.
Since we now have a medication that works sort of okay for macular traction, vitreoplasma, has anyone tried it for vitreopapillary traction?
In my search of the literature, I hadn't seen any reports of that being used for the VP traction. The two main methods that were advocated were just following them serially or doing the actual vitrectomy. But that's a good question.
This can be directed toward you or to the neuro-ophthalmology. The thinning of the